I'm going to start by calling up my first dynamic duo, Blyth Lord and Richard Goldstein. I'm going to put you next to me. So the biographies are in your book. Blyth Lord is the mother of Cameron. And I'm going to ask her to tell us about her experience with Cameron. And her pediatrician was Rick Goldstein. Dr. Goldstein is an amazing person. So the two of them were transformed by their experience together. I want to start by asking Blyth if you would tell us about your beautiful blonde-haired baby, Cameron, and what happened with Cameron.
Can I say one thing before I answer your question? I want to really acknowledge and appreciate the fact that pediatric palliative care gets to be part of this conversation. For reasons that will become clear, that is my primary focus, and it isn't, for understandable reasons, often part of the conversation just because of numbers. But I'm just going to say, as Rebecca has heard me say many times, and Diane as well, if you think palliative care is important for adults who are living with serious illness, imagine how important it is for children and their families when they're living with serious illness. So just going to put a plug in for that. My daughter Cameron was, at the age of 6 months, was diagnosed with the rare and still fatal disease Tay-Sachs, infantile Tay-Sachs. She was she is my second daughter. That's an early age to be diagnosed with Tay-Sachs, but she was diagnosed because the 3 weeks prior, her first cousin, my husband's identical twin's son, had, at the age of 18 months, had been diagnosed with infantile Tay-Sachs. And this was statistically very unlikely, just as genetics go, but it's not impossible. All four parents were carriers. So within a month, we had learned that these two beautiful children in one family were going to die because there was and still is no treatment or cure for for Tay-Sachs disease, period. So for us, it became all about giving our daughter the best quality of life she could have for as long as she had it. And we were incredibly fortunate to have our only doctor at the time, our pediatrician, who we'd known already then for 2 years because he was our older daughter's pediatrician. And he remained our primary doctor all the way through. Rick can tell you, he referred us to, we had a neurologist. We saw a nutritionist at one point, and we saw somebody who specialized in pain management at the very end. But Rick never outsourced her care, and that was a particularly critical piece of our journey with our daughter, because it felt like a team effort and something that was very sacred and really important. And there were some difficult decisions that had to be made along the way, and Rick helped us do that. My husband, Charlie, could be here with me. He's not. We also had also not here we also had a grief counselor who worked with us all the way through our daughter's life and after, and that was another, I'd say those two providers were the most important people on our team.
So, Blyth, can you share with our audience what changes happened in Cameron, what the disease did to Cameron, so they get a sense of what you all experienced?
So Tay-Sachs disease ultimately takes away everything. Basically it's an ultimate suffocation of the central nervous system through a buildup of fatty lipids. And so the body shuts down. It's a very, very painful thing to witness, especially as a parent. Cameron was never able to fully sit up on her own. She certainly never crawled eventually, but she went from being a very animated, happy, cheerful, expressive baby to losing not only her ability to all of her gross motor skills, her ability to sit, her ability to roll over, her ability to use her hands. She ultimately lost her ability to show affect in her face, which is a very painful thing. And then eventually they lose the physiological pieces. They lose their ability to swallow. So I think and their seizures, terrible seizures. It's part of the condition. That was one of the few things Rick helped us medicate her seizures, well, with the neurologist, her seizures, and then ability to manage swallowing secretions, because ultimately when children lose their ability to swallow, you get aspiration pneumonias, which is it's just part of, it's a pretty clear trajectory, which in many ways was helpful because Rick was able to tell us what was coming and what we were going to have to think about. So there was a lot of forecasting and anticipatory guidance that happened. And then, so ultimately as a parent, you are going to have to make a decision about feeding and feeding tubes. And we did do that work with Rick, and also based on and we did this also in conversation with my brother and sister-in-law. We had that conversation as the four of us about what we wanted for our children, and that's actually not typical. It's really extraordinary that we had these other couple who we trusted completely who were going through the exact same thing in our family, and we could have made different decisions. We were already very close, but we got much closer in these really profound thing that we were doing together. They lived in New York, we lived in Boston, we saw each other a lot. And together I don't remember having the aha together, but I just know that the four of us together made the decision that for each of us, we didn't want to give our children a feeding tube just because the disease takes away so much that for us, quality of life did not mean quantity of life. And so that was probably the most profound decision we made. And then we had to make a decision about all along the ways as pneumonias progressed. There was eventually a pneumonia that we decided as a couple not to treat. And I hope that doesn't upset anyone. And Rick had to support us through that.
This is about person and family-centered care, so we don't care if it offends anyone. We support you in the decisions, the very difficult decisions that you have to make, and they are the right decisions for you. So for our audience, can you tell me how old was Cameron when Cameron passed away? Oh, I'm sorry. Can you hear me now? So can you tell me how old Cameron was when Cameron passed away?
So she was 5 months, she was almost 6 months old when she was diagnosed, and she died 5 days after her second birthday. My husband's nephew, Hayden, he died when he was 2.5, and Cameron died 5 months later at 2. Yes, so we had 18 months of living into this, where quality of life was what it was all about. Yeah.
I so appreciate your sharing that glimpse into a very difficult time. I'm going to turn to Dr. Goldstein, Rick, if I may. How do you prefer to be? Okay. So Rick, you were the pediatrician for Cameron. I'm just wondering if you can share what it's like to know that you have to present this kind of diagnosis and how you went about doing that.
So let me just say a couple of things that I do think are important here. Dr. Pizzo probably knows that not all pediatricians take every child from an ICU and every NICU, but I was one of those guys who did that. So in my practice, I had hard pediatrics. They were the VIPs of my practice. That's not why, this was a de novo new thing. But in my practice, I had kids home on ventilators. I had kids that never made it outside of the hospital, but wanted a general pediatrician to check in with after birth. So there was no palliative care, but I was drawn to a kind of, I'll say, meaning-based medicine, a very sort of one that reckoned with the primal responsibilities that parents have for their children, regardless of what happens. So that's one thing that that's just as a matter of disclosure. The other thing to say is that Blyth had a firstborn, Taylor, who was the same age as my firstborn, Isabel, and they went to the same preschool. And Cameron was born within a month of my secondborn, Raphael. And, in medicine, it's often about looking through a window. A lot of my care was about looking into a mirror here. And that challenged me in an important way. That's very particular. Cameron Lord is somebody that I just carry with me through my life and my career, and is so important to who I am. Just because I learned not just about the provision of care and the responsibilities and all the complications, but I learned about myself, and I learned about a kind of empathic medicine. So the simple answer to your question is that it was horrible. It was horrible to say to these people that their child was going to have a diagnosis that had a very predictable trajectory, predictable in terms of a relational a relational person there. I knew that the seizures would worsen, and then be intractable and nonstop, and they would lose access to an important part of who their child was. And I needed to help them steel themselves for that. And oh, by the way, your child will die shortly afterwards, and I needed to steel them for that. And so I think that our first interactions are fairly typical for what happens when people are a little bit over their head. I focused on the technical. I made sure about the certainty of the diagnosis. I talked to the people in the labs that were giving me the information. Blyth was breastfeeding, and that affected, right? It affected the test results. It affected the kind of confirmation that had to occur. So I dug in to that a lot. And the other thing that I did, which happens in pediatrics when you're a little bit over your head, is that I turned to the other children, and I made sure, as a first priority when I shared the news, that they felt that to whatever degree possible, we weren't hurting Taylor, their other child, with this. And I knew that was important. It was important to me to feel that way, but I knew it would be important to them. And I identified their supports. It was right around Thanksgiving. And I knew that the family was coming together. I knew that there was urgency in the air to hear about the diagnosis, and I identified what we needed to take care of right then, which really wasn't very much, and set a plan, which Charlie, who's not here, cared a lot about. Guys like action, they like plans. So I set a plan with him for how we were going to circle back and deal with it. Those are the logistics of it. The kind of human aspect of being a physician in a moment when there is such extraordinary attention on what's going to come out of your mouth, and then to watch it float out of your mouth and come out of you by gesture, and see the air leave the room. Blyth swooned. I've only had one person who I could use that word in my career who has swooned. She fell out of her chair. And I had a desk between us, and she and her husband were there. They were as braced as they could be. But we drew together. It was black and tender at the same time. And then I gave them some time because I knew that however they were going to get through, it would be their solution. And the more I could help them get to their solution, the better off things would be.
I believe your words to us, their first words when we came into your office were, I mean, you ushered, there was a lot of care as you brought us in.
Can I say something first? Yeah. So I used to go out to the waiting room. I walked my patients into my room. I was holding all this awful information, and I'm a terrible liar. My face just revealed everything. I could not make it to the room. I think it was about 5 feet from the door. And then I turned to you, and you kind of already knew. And I said,
I'm sorry. Those were Rick's first words. And then they were your only words for a while, which is, needless to say, the only thing one could really say.
You knew before he said those words. I remember hearing about you're seeing a startle and looking online.
Well, that was the only reason we were worried about my daughter, because it was so statistically unlikely that she would also have it. But when my nephew was diagnosed with Tay-Sachs, I went online and I read about it, and I concluded that, both parents have to be carriers, and I concluded that my husband was a carrier because he's an identical twin. And then it became a possibility that I was a carrier. Anyone can be a carrier, as we should all know, but it was even more likely that I could be a carrier because my grandmother was of Russian Jewish descent. So even though my husband's mutation they had never seen before, and my sister-in-law's mutation they had never seen before, mine, as it turns out, is the mutation that they have seen before. And I went and got tested, and the genetic counselor at the Brigham, when I went to be tested, said, we're going to do this, but it's so unlikely that you're a carrier, because it would be so unlikely that all 4 parents would be carriers. But it came back as a positive, and that was just the DNA. So then she said, no, that was just the enzyme. That was just the enzyme test.
That was affected by the breast milk.
So that was a possibility. So then we went and had.
Told ourselves that was affected.
Then they said, maybe that's a false positive. And then we had then they took another sample to test for the DNA. And they also, at that moment, tested Cameron. We had resisted testing Cameron. And those were the results that Rick got to share. And so there were 10 days between the second test, and the meeting in Rick's office. I think it was 10 days. And those were the most hellacious of, well, it was like all bad, but maybe those were the worst, because you're holding on to hope and you're also waiting for this bomb to fall on you, and you know it's very likely that the bomb could fall on you. So how do you, I remember, as Rick said, our children were in the preschool together, and I saw him at some school event during that time, and it was very hard to see you because we were all in this thing together, but not trying to talk about this thing because we were in the waiting. The waiting is a dark space. Yeah.
Lori? Thank you.
Oh, time.
So this ability to prepare you and to comfort you and to help your family through and offer grieving services, this transformed you and your family, and it transformed you as a provider from a pediatrician into something very different. I'd like to start with you, Blyth. If you can tell me a bit about your transformation, having lost Cameron, using this as the teachable moment, how has this transformed your life?
Well, what happened was after Cameron died, we reflected upon the things that had gone well for us and compared it to even my brother and sister-in-law, who did not receive what turns out was palliative care from their primary care doctor. And there were things that did not go well for them, which we learned from and were able to do differently, partially because we knew what we didn't want and partially because we had Rick to help us. So I saw firsthand that the value of palliative care, and I wanted all parents in this situation to receive palliative care. And it became my mission to make it known that for pediatric palliative care as a field to grow. And we started a small family foundation called the Cameron and Hayden Lloyd Foundation, funded initially by the grandparents and now by friends and family every year. And with that funding, we promote pediatric palliative care programming and research, and also medical research. So that was over here. So that's what we did. But then that was not enough. Then I actually wanted to do the work. I didn't want to just fund the work. So I started Courageous Parents Network as a web and mobile platform to help families hear from other families who have gone before and be in community with each other. It's a nonprofit. Find each other, learn from each other, basically do for each other what Tim and Allison and Charlie and I were able to do as a foursome, and to promote palliative care. We use it as a platform for parents who have received palliative care to share their story with families who don't yet know about it, so that families can find it, understand its value, ask for it, say yes if they're referred to it, and not run for the hills thinking it means hospice and my kid is dying and giving up hope and all the stuff we know that people associate with palliative care. And so that is what I have done with it. And it is, and I, to this day, weekly, monthly, I'm meeting families who are receiving it, and I'm meeting families who aren't, and I can always tell the difference.
Such an incredible story, and having seen the resources, the teaching resources for clinicians, the help to parents, my hat's off to you. Rick, you've had your own transformation. You were an exceptional pediatrician before the field of palliative care. And what did this experience do for you?
Well, I thought it was really great primary care, and felt energized and more convinced than ever that, boy, you can do great things in primary care. And then three things happened. The big they, sped up our workday and made us see more and more patients. They put an electronic medical record, as in a computer screen, between me and my patients, and palliative care as a field emerged. And I knew some people that were early implementers, pioneers in the field, and liked them, liked what they were about, liked what they were talking about, and so moved in that direction and left the community. But now practice palliative care at Boston Children's and Dana-Farber. So I made a pretty big career change.
Can I say a thing? So in my work, I meet a lot of families who go through Dana-Farber and Children's Hospital, and I hear about those who have had Dr. Goldstein as their palliative care doctor. I hear about it, and he's still working his magic with these other families.
You're continuing to make her proud.
I try every day.
As a final note, I'm wondering, Dr. Goldstein, if you would explain the difference between primary and specialty palliative care.
Yeah. So I guess different people might have different answers. I think principally this distinction exists for different reasons than what we're talking about. I think the skill set for primary palliative care is and ought to be a generalist, enhanced communication, relational kind of medical care that places a great premium on continuity of care and effective, sensitive communication. So that's primary care, that's palliative care. To me, primary palliative care has to do with a resource issue, which is that people that are subspecialty trained in this field can't and shouldn't be dealing with every person who's sick and every person who's dying. But among that group of patients, there are some who just have higher levels of needs based upon their pre-existing histories, based upon the symptom progression, based upon how medicalized their lives are after the diagnosis. And so to me, subspecialty palliative care, in addition to informing and supporting primary palliative care, has an important focus in that way. And that carries across all areas. But the power of this idea of primary palliative care is that there is no clinician, there is no person who assumes the responsibility of going in and saying, I'm going to care for you, I'm going to care for your family, who should not be taking this on. It's fundamental to the social construct of what a healer is, but also what just a clinician is. And I think one of the important aspects of primary palliative care is that it puts it back in the hands of everyone and says, well, if I think it's too hard, there are probably some constructive things that I can do here to do this better, because it is on me. Because the primary care clinicians in our lives are in an extraordinarily powerful situation to do this very well, to do most parts of this very well. And that's what I think the distinction is.
So I want to thank our first two panelists. It was exceptionally generous of both of you to share so personally and meaningfully with this group. Thank you, Blyth. Thank you, Rick.
May I be myself and just put in one little last thing? So I feel very grateful that pediatrics is first, like Blyth said. We're kind of a rounding error in terms of patient numbers. In palliative care, we're a rounding error in terms of costs and charges. But I think pediatrics is important because the way we treat the sickest of our children really reflects in very important ways on who we are as a people, what we choose to respond to, what we say is important and worth investing in. And while, and the reason I'm saying this is that the Affordable Care Act, even if Obama was still president, would change. But it has a provision in it for, what's it called? Concurrent care in children. And in pediatrics, if we lose concurrent care in children, we can't do what we're none of this is, this was possible before concurrent care in children, but the field that's grown up around it would be gutted by the loss of that. And it's an important frame, I think, for the day and for this whole workshop, and I'm really promoting that we put it on the top of our list, because in the media and in the political debate right now, there's all sorts of attention to pre-existing illness, and there's all sorts of attention to keeping your kids on your health policies till 28. But we have to watch out for the most vulnerable, and that's Blyth and her family, to give it a human face, and that's the families that we deal with in pediatric palliative care. So I just wanted to insert that.
I thank you. I'm hoping that you show your appreciation to Blyth and Rick. And I'd now like to call up Diane Meyer and Susie West.